Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of February 2nd, 2026. As health professionals rooted in East Oakland facing some of the widest health disparities in the nation, we're here to bring you timely public health information relevant to us all. This week, we are also kicking off a month of specially prepared briefings in honor of Black History Month. Throughout February, in addition to covering current public health issues, we'll be highlighting key moments in Black medical history that continue to shape public health today. This week, we'll be discussing the influential Flexner report and the continued use of race corrections in medicine. And for this month only, instead of ending with States Watch, we will be introducing a new limited segment called Black Health Pioneers, where we spotlight Black individuals whose contributions have been crucial to modern medicine. Before we move into that Black History Month focused content, we do need to address one major current event with significant public health implications: the United States decision to leave the World Health Organization. With that context in mind, we'll begin, as always, with our update on contagious illnesses across the country. First, the weekly percent positivity chart, which shows the proportion of clinical tests coming back positive for each respiratory virus. Flu continues to account for the largest share of respiratory virus detections. And while flu activity appears to be making up a reduced share following a holiday season peak, that decline is slowing and beginning to level off. And this pattern often precedes a second rise in cases around this time of year. Turning to flu activity, many states are now showing rising case counts, reinforcing concerns that a second wave may be approaching. At the same time, some states continue to see declines or no significant change at all. Next, let's take a look at COVID epidemic trends. As a reminder, these forecasts are primarily based on emergency department visits, which give us a near real-time snapshot of what's happening in communities. Currently, COVID activity is stable in most states, but we're beginning to see increasing numbers in a growing number of states, especially in the South, while some states are still experiencing declines. Looking at hospitalizations, flu-related admissions are decreasing, while RSV and COVID-19 hospitalizations remain relatively low and stable. Now on to flu view. We know that influenza can be severe and in some cases deadly, and can certainly lead to a high burden of hospitalizations. So far this season, there have been approximately 11,000 flu-related deaths, including 52 pediatric deaths. There have been an estimated 20 million illnesses and 270,000 hospitalizations nationwide. It's important to remember these figures reflect reported cases and true numbers are likely higher. Finally, a brief update on measles. Cases continue to rise across the country, with South Carolina seeing a significant surge, an increase of 52 cases between January 27th and January 30th alone, bringing the state's total to 847 cases since the outbreak began in October. Nationwide, the United States has already reached 588 cases. Last year, which saw over 2,200 cases for the entire year, the highest number of measles cases since 1991, we didn't surpass 600 cases until early in April, so we are off to a very fast start here in 2026. And in all of 2024, there were just 285 cases for the entire year. So we are definitely heading in the wrong direction quickly. This trend is not limited to the United States. Canada lost its measles elimination status last November, and the United Kingdom lost its status just last week. Unfortunately, the United States may soon follow, despite ongoing efforts by public health experts to curtail the outbreak. If you'd like a deeper look at measles, including the South Carolina outbreak and what it means going forward, including some details about the potential loss of elimination status, watch our previous episode linked in the post where we explored this in detail. Before we get into our Black History Month themed content, we need to cover a major development with potentially wide-ranging public health implications. The United States has officially withdrawn from the World Health Organization. On January 22nd, 2026, the United States completed its withdrawal from the World Health Organization, a United Nations agency that the U.S. helped found in 1948 and supported for nearly 8 decades. Federal officials have cited concerns about the WHO's handling of the COVID-19 pandemic, governance issues, and funding structures as justifications for this decision. From a public health perspective, this is a deeply concerning move and one we believe will likely harm both the health of people in the United States and the health of communities around the world. The WHO plays a central role in global disease surveillance, coordinating real-time data sharing on emerging infectious threats like influenza, measles, polio, and novel pathogens. This information directly informs vaccine development, including the annual flu vaccine. It informs outbreak response and preparedness efforts in the United States. Leaving the WHO weakens our access to early warning systems that help prevent small outbreaks from becoming global crises. Public health experts have warned that this withdrawal makes the United States more vulnerable, not less, to future pandemics. We know that infectious diseases do not respect borders, and global health security depends on cooperation, transparency, and shared infrastructure. Stepping away from those systems does not isolate risk, it concentrates it. The consequences extend beyond U.S. borders. The loss of U.S. participation and funding will likely undermine international efforts to control infectious diseases, support maternal and child health, and respond quickly to health emergencies, particularly in low-resource settings. When global health systems are weakened anywhere, the effects are felt everywhere. While the U.S. government has stated it will pursue bilateral partnerships and continue international health work through agencies like the CDC and HHS, these efforts cannot fully replace the scale, coordination, and legitimacy of a global body like the World Health Organization. At a moment when measles is resurging, influenza remains unpredictable, and new threats continue to emerge, withdrawing from the world's primary global health organization is not just a policy shift, it is a public health risk. We will continue to monitor this decision closely and keep our community informed about what it means for health, safety, and preparedness here at home and around the world. Now we are moving into our special Black History Month topics. We'll begin by discussing one of the most influential and consequential documents in modern medical history, the Flexner Report. To introduce this topic and walk us through its impact, we are joined by Roots Public Health Communications and Research Fellow, Abby Hayes.
Hi, I'm Abby. I usually help write this briefing, so it's a little strange to be on the other side of the camera. Please bear with me. But if there's one topic that could get me here, it's the Flexner Report. As someone with a background in history, I'm deeply interested in how the past continues to shape our present systems. The Flexner Report is one of the clearest examples of how decisions made over a century ago still affect medicine today. In 1910, Abraham Flexner published what became known as the Flexner Report. It was commissioned by the Carnegie Foundation at the urging of the American Medical Association. Importantly, Flexner was not a physician, nor did he have any formal medical training. He was a school teacher who had previously written a critical account on American universities. The Carnegie Foundation was impressed by that work and asked him to conduct a similar evaluation of medical schools across the United States and Canada. The report was framed as a quality improvement effort. At the time, medical education in the United States was largely unregulated. There were no standardized curricula, no consistent requirements for admission, and no agreed upon length or quality of training. Flexner's report offered recommendations for reforming medical education, including curricular changes and financial restructuring. To fully unpack the Flexner Report and all of its effects would take far more time than we have here. So, for the sake of this briefing and everyone's sanity, we are going to focus on just one aspect: its impact on Black medical education. In this book-length report, Flexner devoted less than 2 pages to the education of Black Americans. But within those 2 pages, he laid the groundwork for consequences that would devastate Black medical professionals and Black communities for generations. I want to focus on 2 major outcomes of that chapter: the closure of Black medical schools and the lasting shortage of Black surgeons. Let's start with the closure of Black medical schools. In the final paragraph of his chapter on Black medical education, Flexner wrote, "The upbuilding of Howard and Meharry will profit the nation much more than the inadequate maintenance of a larger number of schools. They are, of course, unequal to the need and opportunity, but nothing will be gained by way of satisfying the need or of rising to the opportunity through the survival of feeble, ill-equipped institutions, quite regardless of the spirit which animates the promoters." That paragraph alone had a profound and destructive impact. As a direct result of the Flexner report, 5 Black medical schools closed, leaving Howard and Meharry as the only Black medical schools in the United States. A recent study estimates that had these schools remained open, they could have trained between 27,000 and 35,000 additional Black physicians by 2019. In that year alone, there would have been 355 more Black graduating physicians, a 29% increase in the actual number. This loss matters deeply. It represents not only restricted access to the medical profession for Black individuals, but also reduced access to quality care for Black communities. When Black physicians are systematically excluded, entire communities lose advocates, culturally responsive care, and providers who understand their lived experiences. The closure of Black medical schools was part of a broader movement to professionalize medicine in ways that benefited primarily white, wealthy men. The Flexner report promoted medicine as an elite profession by reducing the number of physicians through school closures. That exclusivity came at a direct expense of Black institutions and Black students. Today, there are only 4 Black medical schools: Howard, Meharry, Morehouse, and Charles R. Drew. These schools represent just 3% of medical schools in the United States. Yet in 2015, they produced 18% of Black medical graduates. Still, in 2018, only 5% of practicing physicians identified as Black, while Black Americans made up 13% of the US population. This imbalance is not accidental. It is a direct legacy of the Flexner report. The second major consequence of the report that we're going to talk about today is the continued lack of Black surgeons. In his chapter, Flexner argued that Black physicians should be trained primarily to teach hygiene and basic medical principles within Black communities. Flexner stated, "The pioneer work in educating the race to know and to practice fundamental hygienic principles must be done largely by the Negro doctor and the Negro nurse. It is important that they both be sensibly and effectively trained at the level at which their services are now important." This framing limited Black medical education to a narrow scope of practice and positioned Black physicians as a means of controlling disease rather than as full medical professionals. And not just as a means of controlling disease, but as a means of controlling disease to protect white communities. Black individuals did not need to be taught about hygiene to protect themselves and their communities. They needed to be taught so that they could not infect the neighboring white communities. This idea shaped generations of medical training and opportunity. Many Black physicians still see activism as inseparable from their professional identities and feel a responsibility to serve their communities through primary care. While primary care is essential and undervalued, the expectation that Black physicians should occupy these roles at disproportionate numbers is rooted in historical constraints imposed by the Flexner report. This history does not suggest that Black physicians should not work in primary care. Rather, it shows how medical systems have limited choices, access, and opportunity, pushing Black physicians into specific roles while excluding them from others, including surgery. We need Black surgeons.
It's important to sit with what Abby just described. By framing Black doctors as those meant to teach hygiene to Black patients, Flexner wasn't just recommending a medical specialty. He was essentially arguing that Black doctors should be the health police for their own communities. The goal was not to empower Black physicians to provide full spectrum, high level care. It was to use them as a tool to protect the white population from the so called threat of disease from Black neighborhoods. So when we see the Flexner report praised for modernizing medical education, we have to ask, modernization for whom? In fewer than 2 pages, the report helped dismantle Black medical education, restrict professional choice, and shape inequities we still see today. These outcomes were not side effects. They are the result of decisions rooted in racism, exclusion, and unequal valuation of whose health matters. Understanding the Flexner report is essential to understanding modern health disparities, workforce inequities, and the ongoing need for structural change in medicine. As we move through this month of Black History Month briefings, we will continue to examine how history lives on in today's policies, practices, and health outcomes, and why confronting that history is necessary for building a more just and equitable future in healthcare. Understanding the Flexner report helps us see that racial inequity in medicine isn't accidental and it isn't new. It was built into the system from the start through decisions about who could be trained, what kind of care they were expected to provide, and whose lives were prioritized. And that logic did not disappear with time. Instead, it evolved. Today, it shows up not only in medical education, but in the clinical tools we still use to diagnose and treat patients. One of the clearest examples of this is race corrections in medicine, where race is still treated as a biology rather than a reflection of social and structural inequity, and that's what we'll turn to next. In 2020, the American Medical Association made a significant statement. It called for ridding U.S. healthcare of racial essentialism. In plain terms, the AMA acknowledged that race is a social construct, not a biological one, and urged medicine to stop using race as a stand-in for ancestry, genetics, or biology. Instead, it called for race-conscious medicine, an approach that recognizes how racism shapes health, moving away from the long-standing model of race-based medicine. That statement mattered because for centuries, medicine has treated race as a biological fact. In the 18th and 19th centuries, scientists argued that nature created racial differences, using those claims to justify slavery, racial oppression, and white supremacism. And while medicine has advanced, many of these assumptions never fully disappeared. In fact, the racial concept of disease is still what many U.S. medical schools teach their students today. As a result, race continues to appear in clinical algorithms, the tools doctors use to diagnose disease and guide treatment. These are known as race corrections, and they exist across multiple fields. A major 2020 paper documented the continued use of race correction in cardiology, obstetrics, oncology, pulmonology, and beyond. Race correction often stems from a fundamental misunderstanding of what race is and how it relates to past and present racism. It offers an oversimplified answer to an extremely complex problem, one shaped by history, inequality, and social conditions, which is precisely what makes it so flawed. Race is a poor proxy for genetic ancestry. Large genetic studies have consistently shown that there's more variation within so-called racial groups than between them. While racial and ethnic differences in how health outcomes do exist, they reflect complex interrelated social and biological pathways. Race may not be written into DNA, but it has real effects on health, effects that originate in social inequities, and a legacy of discriminatory institutions. Removing race corrections does not mean that race doesn't matter. It means acknowledging that the problem is far more complicated than the color of one's skin. For this briefing, we're going to focus on one of the most well-known and consequential examples, which is kidney function. Doctors estimate kidney health using a measure called eGFR, or estimated glomerular filtration rate. It's calculated from a blood test that measures creatinine, a waste product produced by muscles and filtered out by healthy kidneys. Because directly measuring kidney function is expensive and time-consuming, eGFR is used instead. In short, eGFR tells clinicians how well the kidneys are removing toxins from the blood. Here's the problem. For decades, the most widely used eGFR equations included a race adjustment. If a patient was classified as Black, the formula automatically produced a higher estimate of kidney function, making Black patients' kidneys appear healthier than they actually were. These race adjustments increased eGFR values by roughly 16 to 18%. The correction was based on assumptions, not biology. It originated from statistical analyses that observed higher creatinine levels in some Black patients and concluded, without evidence, that race was an independent predictor of glomerular filtration rate. The researchers hypothesized, without evidence, that this was a result of Black people having greater muscle mass. Meanwhile, social and structural factors such as hypertension, diabetes, access to care, environmental exposure, and chronic stress were largely ignored. The consequences are serious. A higher eGFR can delay the diagnosis of chronic kidney disease, referrals to specialists, preparation for dialysis, and eligibility for the kidney transplant waitlist. Physicians are missing early stages of kidney disease in Black patients, delaying prevention efforts at the very moments when intervention matters most. One study found that removing the race correction would reclassify 1/3 of Black patients into more advanced stages of chronic kidney disease. An additional 3% would immediately qualify for greater kidney transplant priority. That 3% represents thousands of Black people being told they aren't sick enough for a kidney just because a math equation is overestimating their health based on their race. This is especially alarming given that Black Americans make up about 13% of the US population, yet account for more than 35% of patients receiving dialysis and are 4 times more likely to develop kidney failure. For biracial individuals, race-adjusted algorithms expose the deep contradictions of race corrections. Classification as Black or not Black can determine whether someone qualifies for the transplant waitlist at all. Often, that classification is left to provider discretion based on appearance, assumptions, or incomplete self-identification. 2 siblings with the same parents, the same lab values, and the same kidney function can receive different clinical decisions simply because of how race is assigned. In 2021, the National Kidney Foundation and the American Society of Nephrology officially recommended removing race from eGFR calculations and released a race-neutral equation. Many laboratories have updated their reporting, but not all clinicians have changed their practice. And kidney function is just one example. Race corrections have also been used in obstetrics, lung function testing, and even outside of medicine. The National Football League, for instance, used race-based cognitive algorithms that assumed Black players started with a lower baseline cognitive function. As a result, Black former players were less likely to qualify for compensation for concussion-related neurological damage, even when they received the same raw test scores as white players. This program only changed in 2021 as a result of a $1 billion lawsuit. We must confront how medicine's long history of racism has distorted our modern understanding of race and its role in health and healthcare. We will examine shocking race corrections in birth outcomes and lung function in future briefings. Now we will talk about the future of medicine and artificial intelligence. AI and machine learning are being used more and more to guide clinical decisions, but these models are trained on data from a healthcare system already riddled with racist inequities. That means the algorithms themselves can become incidentally racist, perpetuating or even worsening the disparities we've seen with race corrections. Without careful oversight, AI could make the same mistakes at scale, producing worse outcomes for Black patients, just as race-based equations have done and continue to do. Here's what you can do. You have the right to ask questions about your care. You can ask your doctor whether race-based corrections are being used. You can request race-neutral calculations. And you can ask for the raw numbers like lab data, not just the adjusted results. Race is not written into our DNA, but racism has been written into our systems. Changing that starts with understanding it, questioning it, and refusing to let outdated assumptions continue to shape modern care. As we've just discussed, race corrections show us how deeply historical ideas about race remain embedded in modern medicine. Even when science has changed, the assumptions have often stayed the same. Clinical tools, algorithms, and equations still carry the same imprint of a system that treated race as a biology and inequality as inevitable. But this history is not just about harmful policies or flawed equations, it's also about the people who challenge them. The persistence of race correction exists alongside another often overlooked truth. Black medical professionals have long recognized these problems, questioned them, and worked to protect their communities despite structural barriers. From pushing back against race-based assumptions to building alternative models of care, Black physicians, researchers, and public health leaders have consistently advanced medicine towards greater equity, even when the system resisted change. So in honor of Black History Month, we will take a moment to honor a Black individual whose work fundamentally shaped the history of medicine. And we're starting with Charles Drew, because you can't talk about Black pioneers in medicine without knowing about Charles Drew. You may already recognize his name, and if you don't, there's a good chance you benefited from his work anyway. Charles Drew is often called the father of the blood bank, and that title exists for a reason. Charles Richard Drew was born in 1904 in Washington, D.C., at a time when the doors to medicine were firmly closed to most Black Americans, shaped in part by the legacy of the Flexner Report. Still, he pushed forward. He attended Amherst College in Massachusetts, where he was one of just 13 Black students among hundreds. From the very beginning, Drew's education meant navigating spaces that were never designed for him to succeed. When it came time for medical school, Drew had to leave the United States entirely. Very few American medical schools accepted Black students, and most of those who did accepted so few. So Drew went north to McGill University in Montreal. There, during his residency, he worked with a bacteriology professor, studying how blood and fluids could be used to treat shock. That work planted a seed that would grow into a lifelong focus on transfusion medicine. After graduating in 1933, Charles Drew returned to the United States to teach at Howard University. But his curiosity and his sense of purpose pulled him further. He enrolled at Columbia University for doctoral studies, becoming the first person of African ancestry to earn a medical doctorate there. His research centered on blood storage and plasma, a topic that at that time had the potential to save lives on an entirely new scale. To understand why his work mattered so much, it helps to understand blood itself. Blood has two main components: red blood cells, which carry oxygen, and plasma, a liquid rich in proteins and electrolytes that helps the body recover from trauma and shock. Plasma can be preserved longer than whole blood and can be used for people of all blood types. In the middle of World War II, that difference meant survival. After completing his doctorate, Drew was recruited to lead the Blood for Britain project. Britain was desperate for blood supplies as the war intensified, and Drew was tasked with solving a problem no one else had solved before: how to safely collect, store, and ship plasma at scale. He created standardized procedures, insisted on rigorous quality control, and helped develop refrigerated mobile donation units, which he called blood mobiles. His work ensured that more than 5,500 vials of safe plasma reached Britain, saving countless lives. But perhaps the most painful chapter of Drew's story came next. When the United States entered the war, Drew was appointed to help lead a national blood banking program for American soldiers. Yet the US government adopted a policy that first excluded and then segregated blood donated by Black Americans. Drew knew this was wrong, not just morally, but scientifically. Plasma does not differ by race. Still, the policy remained. In a bitter irony, Drew himself was barred from donating to the very system he helped create. He refused to accept that. In 1942, he resigned in protest. Drew returned to Howard University, where he served as head of the Department of Surgery and chief of surgery at Freeman's Hospital. For the next 9 years, he trained and mentored young Black physicians, many of whom would go on to serve communities that had long been denied quality medical care. Drew later said that this work, teaching, mentoring, building opportunity, was the greatest and most lasting contribution to medicine. Charles Drew's legacy isn't just found in blood banks or transfusion protocols. It lives in every life saved, every student trained, and every moment where science is used to push back against injustice. As we close today's health briefing, we want to leave you with a clear message. Public health does not exist outside of history. The decisions we make today and the tools we rely upon are shaped by choices made decades and even centuries ago. From the Flexner report's role in narrowing who could become a physician, to the continued use of race corrections in medicine, to current policy decisions like the United States leaving the World Health Organization, we've seen the same pattern repeated again and again. Systems built without equity produce unequal outcomes. This month, as we honor Black History Month, our goal is not only to remember the past, but to understand how it continues to live in our institutions, our data, and our clinical practices. Health inequities are not a result of biological or individual behavior. They are the result of systems, policies, and assumptions that can be challenged and changed. That is why trusted, community-rooted public health information matters. It is why asking questions about our healthcare system matters. And is why we will continue to use this platform to connect history, science, and policy to the realities people experience every day. We encourage you to stay engaged, stay informed, and advocate for care that is evidence-based, equitable, and accountable. We'll continue this work throughout the month, highlighting Black medical history, examining modern public health challenges, and centering the health of our communities. This concludes today's People's Health Briefing. We look forward to seeing you again next Tuesday at 10 a.m. See you then.